Assalamualaikum. So, as we have already started the whole FCA course, and I hope you have all gone through those videos. And anyone would want to also only 90 days left from the exam, January diet. So you must make your 90 days plan in which you must revise the course at least 3 times when you are going for the exam. You can use any resources, any session, anywhere from where you want to get the knowledge. But most of the time, focus on like trauma. I already mentioned that. I will also give the overview from the OHM in next session. So you must go through the OHM, Oxford Handbook of Emergency Medicine, and for management, you must go through the ARC. So if you are following these, you will pick the MCQs easily. So that should be your plan. And this time we will have one session from trauma resuscitation and one session will be from SLO1. So that will be pattern for next session. Today we are going to have a session on orthopedic trauma. In orthopedic trauma, we will discuss about the upper limb injury. So that's the general approach, that how you must approach any trauma. So any trauma case, you must go through EABCD. So you must remember EABCD. E mean catastrophic hemorrhage if there is any bleed, like amputation, injury penetrating a lot of blood vessels. So that's why that cause of the hemorrhagic shock. So you must put pressure on it. Catastrophic, not a minor, okay, any major bleed. And then A for airway. So you must maintain the airway. You must recognize that the airway is compromised or not. So you must fix it. Is the patient facial trauma, anything that is causing the obstruction of the airway? So you must fix it. Then the breathing, you must go through trachea, oxygen saturation, respiratory rate, neck veins, chest movement, chest trauma, any bruise on auscultation, anything you can find, silent chest. So that should be your approach. In C, you must go through the blood pressure. Patient is at hypotension. It can be hemorrhagic. It can be anything that is causing the hypotension. Respiratory rate, tachycardia, capillary refill time. If it is more than 2, that is showing that patient is having shock in a shock. Peripheral organs are not perfused, not well perfused, so patient needs resuscitation. And also the peripheral pulses that will tell you about that they are weak. So that means patient is in a shock. So that next in the D, you must go through the GCS, AVP, you can say the alert, verbal, AVP pain, unresponsive. So that must go through. And blood sugar, that's very important. Pupils. So that will tell you all the information about any head injury. Next, in E, you must go through the everything, spine examination, journal examination, temperature. So that should be your ABCD approach. So in the secondary, that you must go through the focus history, mechanism of time, associated symptom, full head to toe examination. So initial management, you will do the ABCD, anything that you have fixed it, and scan this way, you will see the notice, then you will imply the suspected fracture immediately, control the bleeding, pain management, you will give the analgesia. That's very important. Any patient coming to the department to do the pain management. Neurovascular assessment, that's very important in orthopedic. Whenever a patient is having any fracture, so you must do the neurovascular assessment. That's very important. If anything, if there is any neurovascular compromise, you will refer to the urgently refer to the orthopedic. So if you are doing a procedure, reducing the dislocation. So after that, you must before that you must do the neurovascular assessment, and after that you must do the neurovascular assessment. In investigation, whenever you are going to do the X-rays, always remember that you will get the two views and two joints, one above, one below, and two views. That's the formula of two. You must remember. This is the definitive care, immediate management, initial management. That's the wording, and that's the question you must know. That what does it mean? Okay, initial management is mostly all that what you are going to do, the X-ray, your examination. That's the initial management. So that all comes in the initial management. Immediate is that if you will not do it, that can be life-threatening. Okay. So that means you are going to do the immediate management, like in attention pneumothorax. Immediate management is the needle aspiration. And for if there is a pelvic fracture, so immediate management, if there is a bleeding patient, hypotension, so immediate management is that you are going to apply the pelvic punch to control the bleeding. Like in catastrophic hemorrhage, immediate management is that you are going to apply the pressure. Okay, so that's the immediate management. Definitive management, that's different. Like in tension pneumothorax, definitive management would be chest tube. Like the other example I have given about the catastrophic hemorrhage, that's the surgery. So you will refer to the surgery department. So they are going to do whatever. Uh, so that term you must know what is immediate, what is definitive, what is next step. So that's definitive care, reduce the dislocation, fracture. So tetanus prophylaxis antibiotic for if there is an open wound fracture. So you must need tetanus prophylaxis and antibiotics. If there is a complex injuries like there is a neurovascular involvement, complicated fracture, comminuted fracture, that can't be reduced in the emergency department. If you have done the reduction and it has failed, then definitely you are going to refer to the orthopedic. When you are discharging the patient, that's very important. In emergency department, you can't keep the patient more than 4 hours. Either you have to discharge the patient, either you have to refer to the referring department. So either you have to shift the patient to the orthopedic in case of trauma, surgery. So that's very important. If you are discharging, you must give the clear instruction where you have to follow up, where have to follow up. That's very important. So open fractures, compartment syndrome, neurovascular pelvic fracture. So I give the examples of that the immediate intervention. First is the clavicle fractures. So what type of clavicle fracture you can see in this image? distal clavicle fracture. So distal third clavicle fracture. Okay, so that's very easy. You can see that this is the distal part. And if neurovascular examination is normal and there is no communicated fracture, then what are you going to do? How are you going to manage this patient? How are you going to manage? I'm audible. Yeah, distal, we divide it into, on the basis of distal, there is a chances of the ligaments injuries. So I think internet problem. Okay, so that's the chances are involvement of the ligament injury. Okay, uh, it depends on that we discuss. So 1 and 3, that's below above ligament. So that's 1 and 3 classification that is done by managed by conservatively and to that, that what type of fracture it is. Middle. So how will you manage this patient? Carefully. That's very important. That which type of sling you will apply. Okay. Okay. If it is fracture here. So what is important here? So what you must go for this fracture? If it is proximal fracture, proximal third fracture. Yeah, so there is the we will rule out the thoracic injuries and examination is suspected on the basis of secondary survey, impact of trauma, everything. Then we will go for the CT scan to rule out the thoracic. That's very important. So distal clavicle fracture types, distal to cracoclavicle ligament, ligaments intact. So if the ligaments are intact, okay, or there is a partial detachment, then we will do the conservative measure. In this, it is integral, though no ligament. Wherever there is a ligament injury, we will go for the surgical treatment. That's what you must know about it. Middle third clavicle fracture, we discussed that we will apply the figure of 8 brace and for 4 to 8 weeks. That's very important. Proximal third clavicle fracture, so there is a risk of intrathoracic trauma. We will perform the CT scan. and apply the sling mobilization and refer to the orthopedic. That's very useful. Yeah. If there is anything involvement, any injury, then we will accordingly. Then is a scapular injury. So clinical features are very important that arm will be held in adduction. So for that, we will do the scapular Y-view X-ray and management, the conservative sling, eyes, analgesia. That but you can see the both sides the in red arrows there is a fracture above, and on left side you can see fracture. That is chromioclavicle joint injury, very important. So they will not give these type of ligament stretch, but you must know ligament stretched partial rupture. So that's how if there is anything, if you are pulling the cloth, so that will be stretched first stretched. If you are pulling from both sides, it will be stretched. Okay, then it will be there will be a partial rupture, and then there will be a complete rupture. So that's how you must remember ligament stretch, clavicle displaced posterior over acromion. Sorry, ligament stretch in class 1, partial rupture. In type 2, that the AC ligaments are partially ruptured. Complete rupture, displacements, all displacement that you are going to manage surgically, but first and second that you are going to manage conservatively. I think my screen has stopped sharing. Okay, so I was telling that whenever there is a rupture, there is you can see that displacement, posterior displacement, and then is the displacement under the skin. So these are 3, 4, and 5 types. So first two you will manage conservatively because there was only stretch and partial. For other there is a complete displacement. Yes. You will refer to the orthopedic. Then they will manage. Okay, now in the shoulder injuries, there are common 3 types of injuries: anterior, posterior, and inferior dislocation. So anterior dislocation is the most common that can be due to overabduction, extension, and rotation of shoulder. So clinical features are very important for the anterior shoulder dislocation. Arm should be abducted and externally rotated. Okay. So what movement patient can't do? Type of movement patient can't do. They can ask the question anywhere, so you must be ready for it. Yeah, adduction and internal rotation. Patient will not be able to do the adduction and internal rotation. An arm will be held in abducted, externally rotated form. Okay, and inability to touch the contralateral shoulder. So this is the clinical feature of the anterior shoulder dislocation. Investigation, you will do the X-ray and you will also do the assessment, neurovascular assessment. So what type of nerves that can damage an anterior shoulder dislocation? So there are chances that axillary nerve can be damaged in anterior shoulder dislocation. So you must also know the axillary nerve supply. Okay, they can ask in the question. So what is the sensory supply and motor supply? First, tell me the motor supply. Which muscles are supplied by the axillary nerve? Not infraspinatus. Axillary nerve deltoid, yeah, deltoid. The other muscle, trace manner. Yeah. So you must remember that these two muscles, these are supplied by the axillary nerve. So axillary nerve. So they can also give the loss of, in the option you will see multiple options. So they can give that which muscle patient will know. So they will show you the X-ray of anterior shoulder dislocation. In the option, they can ask which type of movement patient will not be able to do. So they can give that patient is unable to do the abduct. Okay. Axillary nerve is damaged, so it's a medial rotation. So that's uh, like external rotation, internal rotation, adduction, and inability to touch the contralateral shoulder. So that's feature you must know. Sensory supply, they can ask that it's supplying the regimental area. So these you must remember. So management, the same ABCD approach, and you will give the analgesia. If you are going to reduce it, then you will give the procedural sedation. Pulse sensation, post reduction, immobilize and sling, and arrange orthopedic follow-up. That should be your management plan. Reduction techniques, there are many reduction techniques, modified Kochel method, Stimson technique. So you can see on the normal shoulder on the right side, okay, this one. On X-ray, how does it look and which bone is there? Humeral head, you can see the acromion process. Humeral head is inside the acromion process. Then is the clavicle, distal part of clavicle, coracoid process, glenoid, and body of scapula. So on the right side, you can see that humerus is dislocated. It should be there, but it has been dislocated. Okay? So it's not inside the glenoid, humeral head, humerus. So that's the anterior shoulder dislocation. Then are the reduction techniques. So you must know that modified Kochel method, Cunningham technique. These are reduction technique without that's your. Either they can ask about what movements you do for the modified Kochel method. So you will do the adduction, flexion of the arm, then the internal rotation. That's very important to remember. Three things in the rule. Stimson technique, that you must know that you will hang the arm down over the edge and apply the weight. Modified Mills method, you will abduct the arm to 180 degrees. Okay, next is the Cunningham technique. So you must know which muscle, massage of which muscle you will do. That's very important for OSCE and HP exam. Massage of which muscles you are going to do, and it's gonna help you. deltoid, trapezius, and tricep. Excellent. So these three muscles are very important. You are going to do a drop in these. So you are going to do the massage for these muscles: trapezius, deltoid, and tricep brachii. So saying I'm anterior shoulder dislocation injury to accident RV injury rotator cuff mostly due to greater tuberosity. So rotator cuff you must remember it with the greater tuberosity, but don't confuse it with anterior shoulder. Okay. So if there is involvement of the greater tuberosity, then you must choose the option for rotator cuff injury. Possible associated fracture, human head, greater tuberosity, clavicle, heel sac, laying, and Bankard. We have discussed that heel sac is the early part of the humerus that the posterior lateral humeral head compression fracture. And Bankard is that the avulsion of the anterior glenoid labrum as attachment to the femur cord. Next is the posterior shoulder dislocation. So you will see the light bulb sign. Okay, so most nowadays they don't give this is the common light bulbs as everyone they ask the difference the posterior shoulder dislocation. Clinical features that patient is unable to externally rotate, abduct the apoptic arm. So it is opposite to the anterior shoulder dislocation. So after ABCD, you will do the X-ray. So on X-ray, you will see the light bulb sign. So what type of features you will see? Patient will not be able to how the arm will be held and which movement patient will not be able to do. Yeah, can't do abduction and external rotation, but the arm will be held adducted, already adducted. Okay, so patient will not be able to externally rotate and abduct the affected arm. So you will do the X-ray. On X-ray, you will see the light bulb sign. So it can be reduced. You can reduce under sedation, traction, counter traction method. This is the clear dislocation like xyto erector. So that can be happen due to the hyper abduction force. So clinical features that would be same. That patient arm would be held abducted over the head. Okay, that would be abducted over the head. Elbow is flexed. So we will always remember that anterior dislocation. We will treat it as an interior dislocation. So they can give the X-ray of inferior dislocation. The management they can give all the options from the anterior dislocation. So you must not confuse it. Then there are fracture of humerus. So it can be proximal humerus fracture, middle shaft humerus fracture. Okay, and the most common fractures of the proximal humerus include the surgical neck and greater tuberosity. So which nerve can be damaged in the surgical neck fracture? Axillary. Okay, so that's all the same. Axillary nerve injury. So in proximal humerus fracture, so that can be the surgical neck fracture and tuberosity, and we will do the need classification. If it is a one part, only one part is fractured, then you will do the conservative. If it's two part, three part, multiple communicated, so then you will refer to the orthopedic. How will you mobilize? That's very important with collar and cuff support, and it has been asked previously. So one part fracture, you will immobilize, and if it is immobilized, then you are going to refer to the orthopedic department. So we discussed surgical neck, axillary nerve involvement, rotator cuff that is related to velocity fracture. Rotator cuff injuries, that these are very important in MRCP and also in the MRCS. So you know about the muscle names, it's supraspinatus, infraspinatus, res minor, and the subscapular. So supraspinatus is the first muscle, suprascapular nerve. So it is the most common muscle that can be injured. Function is abduct the arm till 15 degree. Okay, and we and supraspinatus, that the test we do for it, it is empty can test. Okay, so you must only know the name for that. Okay, the empty can test. Whenever you are examine the patient with suspected rotator cuff injury, sits muscles or any, if patient on examination, if when you are going to ask to do the empty can test, you push some pressure, patient feel pains, that is a impingement, okay, not a tear. If patient presented into the emergency department and you are doing the examination, patient is not cooperating, you are unable to do the examination, any test like empty can test, you ask to pull the arm at the level of chest so you can do the empty can test. Patient is unable to do it. That means there is a tear. So you must remember how to differentiate between the tear and impingement or stretch. Okay, if there is a stretch, that will be managed conservatively. If there is a tear, that you are going to do the MRI and then you are going to do refer the patient to the orthopedic. So same for infraspinatus, that is applied by supraclavicular nerve. It is function lateral rotation of arm, teres minor axillary nerve, lateral rotation of arm, and then the subscapular, that same nerve, subscapular nerve. So we do the infraspinatus for infraspinatus test, teres minor, we do the horn blower test, subscapular, we do the lift up test. Okay, so how will you mobilize with the, what type of sling you will use for rotator cuff injury? What type of sling you will use? Broad arm sling. Okay, that's very important. Remember all tests, nerve supply, functions, these you must, that should be on your fingertips. What type of fracture you can see? Middle shaft fracture. Which type of injury you are expecting in this patient? On neurovascular involvement. Okay, yeah. So radial nerve, there is a chances of the injury to the radial nerve. So in the exam, they can give this fracture and they can ask what type of patient will not be able to do the movement. So wrist extension, that's the common question, elbow extension and the arm extension. So extend the radial nerve is applying the extension muscles of the arm, forearm and hand. That's very important. That what type of fracture it is, hairline, transverse, comminuted, spiral, these types are very important. Then the management, you will apply the POPU slab. So that's very important because it has been broken from the middle. So you will apply, uh, cover it from the both. So you are going to immobilize with the U slab. So U slab will cover from both sides. Okay. So that's you must remember. Okay, other thing that's important whenever there is a fracture of the long bones like humerus, femoral, so that you must also suspect the NAI in children. Next are the elbow injuries. So how much you approach to the elbow injuries. So you will check on the X-ray if there is interior pad, posterior pad. So elbow fusion can be felt as tense, bulging swelling between lateral epicondyle and point of olecranon. Look for equilateral triangle with elbow flexed, presence of fat pad sign, that's very important. It is anterior fat pad sign or posterior fat pad sign. So always remember when you are seeing the X-ray in the exam and you are confused that it is radial head fracture or supracanal fracture, so you must go for the age. In children, the most common is supracanal. In adult, that is radial, but can be opposite. So that's the only to memorize. But there can be radial head fracture in children, and they can be status epilepticus. So these are the normal anatomy you can see. Humerus catching with the coronoid process. There is the organ, and then same. That is same. Little epicondyle, medial epicondyle, and capitulum. You can see on both sides. Can you see my screen? Well, it's showing that screen as fast. Slide you can see. Hello. I'm audible. Okay, that's about the fat pad sign or sale sign. Okay, anterior fat pad visible too. due to fat in the joint capsule. It is never normal to see. A posterior fat percent is always abnormal. That's very important to remember. Okay. Then is the elbow classification on the basis of age. That's very important. Tritoe, Critoe. Okay. So C for capitulum, R for radial head, I for internal epicondyle, and T for trochlea, O for olecranon, and E for external epicondyle. And then, so these you must know 1, 3, 5, 7, 9, 11. So they will tell about the age. I think no screen is visible. Okay. So this classification is very important because it's not possible that at the age of 1, someone has developed a radial head. Okay, so that's not possible. Either it's not possible that after capital M, if there is internal epicondyle ossification center is appearing, that means that is showing the fracture. Okay, so you must what how will you remember these? That's how I remember. I will tell you that's it's the radial head everyone knows and capitulum. So here you can see that. So in this you can see capitulum that is convenient 3 crito. So that was radial head. So you can see that paired. Then it was internal epicondyle. Okay, so you can see. Then the trochlea. Okay. Ah. So how will you remember? You know about the internal epicondyle. You know about the external epicondyle. Okay. External epicondyle will be on radial side with the radial head. Okay, outside lateral side. So radial head, if you know radial head, so that's you must remember CR. So above radial head, that is the C. And so I was telling if anything comes first, so that is showing the fracture. Okay, if anything is missing at some age, that's also showing the fracture. Next is the supracranial fracture. Very common questions like supracranial fracture that the age is 3 to 10 years of age and peak at the 7. Classification type 1, type 2, and type 3. So you must know that in type T there will be minimum displacement and posterior fat sign will be present, but it will be a very stable fracture. Okay, stable fracture. So nothing to worry about. You will manage conservatively. Type 2 and type 3 fracture. In type 2, that will be displaced, but cortex will be remain intact. So type 1, you will manage conservatively type 2 and type 3. So type 2, that will be displaced, but cortex will be intact from behind. Okay, so that's how it will be intact a little bit. But in 3, that will be completely displaced from the other bones. So that you must remember. So what type of supraglenoid fracture this is? Classification. One, two, three. And how will you manage? I am audible. Please tell. Yeah, conservatively. So what type of fracture this is in the image? One, two, three. Only three appeal. That is a type 3 because it has been displaced. It's not in touch with the cortex. So type 1, you are going to discharge with analgesia. You will apply the long arm posterior splint or collar and cuff. Collar and cuff is very important previously. And you will keep the elbow at the 90 degrees for 7 days, and then you will ask the patient to have a follow-up in the fracture clinic. Urgent referral for type 2 and type 3. So in that case, we are going to do the urgent referral. So if there is a chances of median nerve injury that you must know. Radial head and neck fracture. So you can see on the right side that it's clear. Radial head fracture. So radial and ulnar fracture that is commonly associated with trampoline. So there is a S6 in that you must know about it. There is a triangular, three things. Triangular fibrocartilage complex of the wrist. And then is the introtious membrane between the radius and ulna, association of the radial ulnar joint. So you must know about the S6 three things. Triangular fibrocartilage complex of the wrist, introtious membrane of the radius ulna, and distal radial ulnar joint dissociation. Radial head and neck fractures that are very important. So it can be happen due to when the patient will be doing the pronation, supination of the arm, will feel the pain. There can be the swelling. PrepXperts line on X-ray. We have discussed abdominal deflection on the radio capital line. So if there is a non-displaced fracture, we will manage conservatively. If there is a displaced fracture, we will refer to the orthopedic fracture clinic. Okay, next is the olecranon fracture. So that can be isolated or it can be connected with any radial head or other fracture. So what you can see on the X-ray. What you can see in this X-ray. That is the olecranon fracture. This diagram may have been given in the exam. So that's also the same olecranon fractures. Okay, today till we are teaching session till there. Next we will discuss the elbow. Okay, and we will also have an overview from the either we will over on one day after finishing the upper limb diagram. Who have read the trauma from Oxford and Book of Eminence? I'm audible. Okay, see you tomorrow. So tomorrow or day after tomorrow, I will tell you. Okay, that's good. If you have done that. Okay, thank you.